SLT. Now it's an honor for me to invite the President of the Glaucoma Society of India, Professor Surinder S. Pandav. He heads the Department of Ophthalmology at the Advanced Eye Center Postgraduate Institute at Chandigarh, and is one of the leading figures in glaucoma in India, who has trained from the entire breadth of the country several top surgeons, and also conducts regular CMEs for the public and for trainees. And he's an expert surgeon, and we like to hear his views on using medical therapy as first line rather than SLT. So over to you, Dr. Pandav. Please share your slides.
Thank you, Dr. Tanuj, and thank you, AIUS and APGS for giving this platform. And thank you to Dr. Varun and Dr. Namrita for including me into the program. So I'll be talking about the medical treatment is a better option for treating POAG. Now, Dr. Chan has actually used SLT trial in great detail to give us a very rosy picture about the SLT. But is it really so good? See, ALT or SLT, I mean, the laser treatment that I've measured has been there for more than 40 years. And if things were so rosy, then everyone would have been doing laser these days. But if you look at the ground reality, then the medical treatment remains the first choice of most glaucoma surgeons as of now. And this figure is from a survey conducted on the in Canadian ophthalmologists, where only 17.7% of ophthalmologists use laser trabeculoplasty or SLT as first choice of therapy. And most of that means the overwhelming majority is actually depending on medical treatment for controlling IOP in their patients. Now, why this happens is because most ophthalmologists have more faith in medical treatment in drugs to lower IOP as compared to SLT. Now, problem with the randomized trials is that randomized trials, they are specifically written to design to control to exclude this kind of faith or the trust factor. Now that's important as far as trial is concerned because you want to remove the bias. But when you have a good trial, and people start following that trial, but if they find in the practice that it doesn't match with what they are seeing clinically, then the uptake for the trial is low. And I think something similar seems to have been happening with the SLT, because in 40 years, it has not really been able to gather that much of, the people doing it. There's a number of trials or many other trials out there actually on glaucoma and on the laser SLT as well as LTP. Now this is one of the meta-analysis done of the 8 trials which were randomized controlled trials, and more than 1,200 patients were included, and they found there actually no significant difference between the SLT and medical treatments as far as the IOP lowering is concerned. So something similar is actually in the LIGHT trial also. And there's another review which on the selective laser trabeculoplasty past, present, and future, and it also suggests that medical as well as SLT group, they have almost similar IOP outcomes. However, IOP spikes in the immediate post-laser period is a concern for SLT group or the laser group, and which could be damaging in glaucoma patients, especially if it's a moderate to advanced disease. Now, we have already heard about the LIGHT trial, so I won't go into details of it, but SLT has no added benefit in terms of percentage of lowering IOP reduction, even in the SLT trial. And 1/3 of these patients actually had some kind of a side effect. They may not be visual threatening, but there are side effects of the SLT as well. So it's not free of side effects. And 1/4 of the SLT people, they actually need a second treatment. And also there's a concern for IOP spike even in the LIGHT trial. So if you look at the earlier, this is a summary of some of the trials that we've done earlier. And if you look at the IOP reduction, then the IOP reduction varies from 18% to some, 24%, 28%. But by and large, the tendency for the IOP is to settle down somewhere between 20 and 25%. And other thing I want to point out is the response rate. Now, if you look at the response rate figures, then in different studies, it varies from a meager 53% to maybe 88%, but I think overall response rate is somewhere around, say, about 60%. So I think that doesn't speak very highly of the SLT. So the ground reality is that the average reduction in IOP is overall less than 20%, maybe 20%. And average success rate, if you look at the overall success rate, is somewhere around 50%, maybe less. And percent IOP reduction is not significantly different with SLT and medication. So keeping in this overall, the results in mind, I don't think we should be advocating SLT as a first line of treatment for glaucoma patients. And also, there is a decline in efficacy, and that has also been highlighted in the previous talk. So SLT tend to wane in efficacy with time, and the success rate, if it was at 68% in the beginning, at 1 year, it drops down to almost 46%, and in 3 years, it will just about 1/3 of the patient would be, would be doing well, and 2/3 of the patient would need a retreatment or some other, measure to control intraocular pressure. Another argument sometime, given in favor of SLT is that SLT equals latanoprost or one anti-glaucoma drug, but I think there's no truth in this assertion, because if you look at the data which is available in literature, latanoprost group achieved 90% of the times achieved IOP reduction of more than 20%, whereas this figure is only 82% for SLT. And also, if your target IOP, like 30% or more reduction, then the latanoprost group would achieve their target in about 78% of the cases, whereas the SLT would fall short only at about 59%. So to say that latanoprost is equal, the SLT is equal to latanoprost is not really true. Maybe it might be closer to the timolol, but certainly not closer to the prostaglandin analog. Another issue with the glaucoma patient is the IOP fluctuations, and there's a kind of a belief that maybe SLT gives you more sustained IOP reduction and lowers IOP fluctuation, but this assertion has also been is contradicted or countered by this study, and it says that IOP fluctuations are actually lower with latanoprost, at least in this study. So I think, again, there's no conclusive proof to say that SLT would give you better sustained, less fluctuation, IOP controlled with less fluctuations. Another issue is the cost of treatment, because SLT is also propagated as a something which can reduce the cost of the treatment, but the cost of treatment is very variable across different countries and regions. And now we have availability of generic drugs which are much cheaper than than the original molecules. So SLT definitely comes at a higher cost of investment. You need to buy equipment and need to upgrade from time to time, and the maintenance is required. So it is a costly proposition for any practice. This is another cost analysis, cost of treatment analysis. This was done in 2012. And if you look at this, I just want to draw your attention to the generic latanoprost and the generic latanoprost. And if you look at the time threshold, that is 56.3 months, that is almost 5 years. So what does this mean is that the latanoprost, if you're treating with medical therapy, the cost benefit ratio becomes unfavorable in about 5 years time. So that means latanoprost is better than SLT for 5 years, as far as up to 5 years, as far as the cost of treatment is concerned. And after 5 years, maybe SLT will gain an upper hand, but we are assuming that SLT will be effective for 5 years. And the reality is that SLT effect does not last for 5 years, and probably in 2-3 years times, you will need a retreatment or other medications. And if you're doing retreatment in 3 to 4 years times or in between any time, that will upset the cost advantage which is proposed because of the selective laser trabecoplasty. So I don't think there's any real cost benefit either while you're using selective laser trabecoplasty. Now, medical treatment has many advantages. This is very convenient to use. Is intuitive. You don't need to train people to put eye drops. Of course, some training is required, but it's not that much. And it's more of a counseling rather than training, which is needed. Most patients tolerate drugs, some may not. So for them, you can have alternatives. It's easy to titrate therapy, and there are a number of drugs, and they give you, many number of combinations are possible to suit your patient's needs, which is not possible with SLT. And also the cost of treatment, as I said, is much lower with the medical treatment, especially with generic drugs. And availability is an issue. Most of the drugs are available now all across the world, whereas maybe not in all regions, but still they are available. But availability of the SLT is much lower than the drugs. So That's another issue with the SLT. So LTSC also has other problems like lower efficacy, as mentioned earlier, low response rate, the questionable cost-benefit ratios, IOP spikes, reactivation of VRTs, synaptic formation, corneal clouding, and many other complications have actually been reported with this. And this also could lead to a false belief the IOP is controlled after laser for good and patient may not turn up for follow-up. Again, that could lead to deterioration of their glaucoma condition. So it's not surprising that most of the medical practitioners, glaucoma practitioners, they still prefer a medical therapy as the first preference for their newly diagnosed glaucoma patients. Thank you very much for the opportunity and for patient listening. Thank you.